Good morning. I do have a couple disclosures for research support from Exactech and Tornado, otherwise no other specific funding toward this talk. Total shoulder arthroplasty, we're going to just talk a little bit briefly about the history, indications, some of the techniques I'm really not, and I eliminated for brevity's sake, and then just maybe some of the new advancements and then rehab. Shoulder arthritis is really the diagnoses that we tend to treat are a vast, but majority tend to be osteoarthritis. Rheumatoid arthritis has really decreased over the last 20 years with the improvement of our medications and our medical treatment. And then avascular necrosis, post-traumatic arthritis, rotator cuff arthropathy is a growing field, and the thing that we didn't add here that is a newer ongoing field is proximal humerus fractures. The typical non-operative treatment, I'm sure many of you guys are familiar with. They tend to be the same things that we do for almost any of our arthritic patients. It's really a rest or a RICE type protocol, which is rest, ice, corticosteroids, and other NSAIDs. So non-operative treatment is pretty well known. I think the surgical treatment options are what I was sort of wanting to focus on and talk to you about, and that's for shoulder arthritis in general. I think shoulder arthritis in general has been a newer burgeoning field that has the highest growth right now among the arthrotides and comparative to hip and knee. These are some of the treatment options and sort of cover the gamut here, and we're going to go through some of these. Arthroscopic debridement is the first one I would touch upon. It's a good option for early arthritis for younger patients. Unlike the knee, I don't know if many of you guys know, but the True JAMA article, or actually was a New England Journal of Medicine article, talked about the lack of efficacy for arthroscopic debridement of the knee and for arthritis. And however, the shoulder has still not been proven otherwise. Unfortunately, that has changed our reimbursements because of that article in the New England Journal of Medicine. For the shoulder, however, we have not proven that yet. So there is a couple studies, there's not a lot of good evidence-based medicine, but a couple studies that talk about arthroscopic debridement as an efficacious or an effective way possibly to give pain relief to a young arthritic patient. What they did find out in one of the studies here in 2002 did say that, however, a subset of patients that might fail are people that have greater than 2 centimeters of chondral lesions. So that's where there might be full thickness loss of greater than 2 centimeters. In those patients, perhaps we might not think of arthroscopy. We might think of arthroplasty as an alternative. What does it do? How do we do it? Well, we remove the loose bodies. A lot of times people go after the osteophytes. We do a full synovectomy and talk about debridement or capsular release. A lot of times early arthritis is a causative, and we don't really know if it's a cause or an effect of loss of motion. When you get eccentric wear, you tend to get higher stress strain loads, and that we think may lead to accelerated glenoid wear and perhaps accelerated arthritis in the shoulder. So there is some studies that have been done that if we can rebalance the shoulder, both with rehab and through muscular rebalancings as well as capsular releases, perhaps we might decrease the acceleration or slow down the rate of arthritis that might occur in the shoulder. So resection arthroplasty was done many years ago. It's still used in a certain subset of patients, although with the advances of biomaterials and arthroplasty, really it's probably a less common procedure that had been done over the last 50 years. Resection arthroplasty, we know, does provide historically good pain relief. It's just functionally very limiting. Patients are not satisfied and unfortunately do not get good functional outcomes. There was really not something that I would say in today's day and age would be a primary role. So then the Jones procedure was in the early 1900s. It was a resection arthroplasty and a shoulder rebalancing kind of procedure. Pretty invasive, done very long ago. I think more recently and more commonly, instead of just doing the resection arthroplasty, people have been doing interpositional allografts. So that might be something where they use some sort of soft tissue interposition there to offload the bone-on-bone arthritis, which we think is what is the causative of pain. This is something that was done probably over the last 30 years for young patients with early degenerative changes, but that have larger lesions, right? So we didn't greater than 2 centimeters, we'd say, or full thickness, large subchondral wear with osteophytes, sclerosis, cystic lesions, those type of thing. One thing that we talked about yesterday that Dr. Dye talked about is really MRI's changes. When you see that subchondral edema, it's a good sign, and it's very common in shoulder that is a thought of causative of pain. So they've tried some of these things. What's interesting is this sort of at a burgeoning field, and it's sort of been revisited over the last maybe 5-10 years. So they'll take a meniscal allograft and then they'll re-sew it into the glenoid. What the newer combination now, so that was done with the resection arthroplasty or just some subchondral sort of procedure with debridement. Now it's become a newer procedure with perhaps the arthroplasties. So you're doing something on the humeral head side, you're replacing it, you're capping it as there, and then you're going to put in a soft tissue in a position against the glenoid. The problem with that is and it looks great a year out, but what we found is a lot of the studies have showed there was something by Dr. Romeo that's more recently really published in March of 2014 that talks about a series of these with up to 71% failure rates. And that's about 2 to 3 years out. So, some people say you're giving people 2 to 3 years. Maybe that's something. There is some kind of argument of this in a patient that's 30 years of age. But a lot of people say that that's pretty high failure rates to consider doing something surgically that's so invasive. So even though we're seeing a return of this, I think the results still have not proven themselves, and there's a lot of controversy for it. So arthroplasty. Arthroplasty has really come into advancements over the last probably 50 years, and for the shoulder, probably the last 30, 40 years. 1970s really was sort of the biggest advancement when they developed the total shoulder replacement. So arthroplasty, let's be clear here, it started and developed in the humeral head replacement. There's also minimally invasive options. So you're not replacing just the humeral head, but you're capping it, or you're doing smaller little replacements. Or a total shoulder where you're doing both the humeral head recapping and you're resurfacing the glenoid. So that's kind of what we think of total shoulder or total joint replacement when you look at the hip and the knee. It's the fastest growing segment in the United States with over 50,000 arthroplasties done per year. And it's for shoulder has a greater than 90% satisfaction rate and up to about 20% failure rate. This has improved over the last 20 years. Really, it was probably the highest failure rates out of the arthroplasties. It still is. There's still a lot of room for advancements in the scientific field. I think it is behind the hip and knee in terms of research and biomechanic understandings. However, we're getting greatly improved and accelerated in our research and our abilities to improve these outcomes. When you look at it, obviously this was in 2002. I could not find a similar graph, and they really haven't done an update in 10 years. But I would beg to differ here. Now we're looking at 50 to 100,000 of the shoulder replacements now. So it's really accelerated when you look at the hip and knee. So let's go back to the history of it. It might help you guys and helps me. I think I always tell my residents it really helps me understand where we've come, or where we need to go when you look at where we've come. And I think it's an important thing in research when you're looking at it to really understand the history to not repeat itself. So the first shoulder arthroplasty was done by a French surgeon in 1898. It was done for tuberculosis, and it was a fixed constrained joint. You can see here, pretty invasive, obviously large. It was done with platinum and rubber. Did not do well. At 2 years, it had to be removed, and pretty much no one tried anything for another 50 years. And so in 1950 would be our first modern shoulder replacement by Kruger in Germany. They used Vitalium. And what's interesting about it, which is something that we've revisited and come back around, it just took us 60 years to figure out again, is it was a very small humeral stem. And if you look at it, it had a lot of permeation to allow bone growth in. And so interestingly enough, it was an uncemented prosthesis, and it had some potential for bone ingrowth with a minimally invasive stem. So that was the first one. And then basically in the 1970s, we went from a fixed fulcrum, or a fully constrained one, to what I would call a semi-constrained prosthesis. And that is where I think our modern-day total shoulder has really come from. And that was in 1974, and you'll see in the next few slides, Dr. Neer is really the father, or the grandfather of the total shoulder replacement. So when you look at that compared to hip and knees, I mean, we've only had 30 years of experience, maybe 40 now, right? And so it's kind of amazing that we've advanced so much, and so many people and millions of people are getting relief from this. But I think it's a really true of the science of modern-day medicine, where we put in a lot of things that we don't know what the repercussions are going to be. And so the advancements of technology sometimes overpower the advancements of science and our research abilities. So Dr. Neer was what I would call the father of shoulder arthroplasty. He trained at Columbia. Every shoulder surgeon really comes from two different schools of thought. Dr. Rockwood, who was in Texas, who was a cowboy, and Dr. Neer, who was in Columbia, who was a gentleman. And so pretty much most shoulder surgeons in the entire United States have come from one of the two lineages. I am a Rockwood and Neer trained surgeon because I trained at Cleveland Clinic, and one of my mentors trained with Rockwood and one trained with Neer. And so I think there's very interesting sciences and developments that have come from the shoulder arthroplasty world because of the two. So initially, it was done for fractures, ironically. If you can see here, it's a pretty larger stem from the first Vitalium one that we talked about. So we went backwards before we come back to being forward here. And so this was done for fractures, but interestingly enough, it had okay results for the arthritis type patient. So for degenerative changes, it really was okay, but fractures, it was better. So then that was in 1970 or 1955, we kind of have our first stems like we talked about. And then in 1970s, we developed what I would call the total shoulder. And this is really the generation 2 of the Neer. And you're going to see the next one, they had modular heads. So you could change. So at first, it was a uniblock type metal. And then we started getting some ideas of, okay, not everybody is 5'5" and 170 pounds. We've got a lot of variation in our population. So it started doing more anatomic modular heads. And then they started developing the socket side for the total shoulder. And so the results from the initial one, these are what you're near to, or what I'd call the generation of the beginning of total shoulder. And the concept was, instead of doing a conforming, completely constrained joint, they did a non-conforming or minimally constrained design. And that was one where basically you have a conforming piece of metal that would recreate the anatomy of your humeral head. And then you have a socket that's really a different mismatch. So there is a level of sloppiness, I would say, or a level of mismatch or nonconformity that exists in the shoulder that's not in the knee, that's not in the hip. And that nonconforming design is really because the shoulder is so much based on the muscular dynamic forces, and it tends to be a lot longer or more anatomic in terms of recreation of the shoulder biomechanics. So that stability was dependent on the soft tissues, and that's a big advancement from the shoulder field of how that was done. So then that was the second generation when we started getting more variety. You can see here of different head types and different sizes and different things. And then we started figuring out the socket side. The socket was high failure rates. You can see, unlike the knee and the hip, it's tiny. You know, the glenoid is a very small area and surface area. And so it's still, I think, the next advancements in our future, in my career, is going to be how to make that better and how do we figure that out. But they basically, the designs that they started with metal backed, like every other joint. We have a metal, and then you have plastic in between. Those failed horribly in the shoulder. So for some reason, unlike every other joint, when you have a metal against a polyethylene, that mismatch in loading, even though it's not weight-bearing joint, they failed completely. So those have sort of, no one uses metal backs anymore. And that's a very different thing. So everything now has become sort of all polyethylene, if you look. We tend to cement it. That's an advancement that's probably in debate. I think that will probably in the next 30 years also change. Like other joint replacements, cement has become our devil in orthopedics. And you guys might know, cement is sort of, we moved away from cemented components, period. Because the cement-bone interface tends to fail, and because over time, really bone ingrowth is what I think biology is what you need. And so biomaterials have advanced a lot in orthopedics and shoulder replacements, and that's an area that I think still is, I think, the next bastion. Or the mess, see that we need to cross is sort of improvement on our biomaterials. So polyethylene is something that we work with now, and it's highly cross-linked polyethylene, or at least cross-linked polyethylene. And that is sort of the way of highest wear characteristics, so the durability of that. And then also the advancements on the design side. So we've gotten rid of the metal on the back. We minimize the amount of cement we use. And then we've gone from a keel to a peg design. And I'll show you a little bit about that. So the third generation also is more anatomic. If you look, the humeral head offset, look at the top versus the bottom. You can see the radius of curvature. It changes like a normal anatomy, whereas the top one's just an oval. So we're trying to get better, and we're trying to work on our loading characteristics, and by recreating the anatomy as best you can, you improve the biomechanical loading. So that's where we've gotten adjustable heads. So the indications are still the same. I think we've added some things in there, and I wanted to sort of just highlight nowadays 4-part fractures, proximal humerus fractures are another, and then revisions. It's just a growing field in shoulder. When people are putting more in, we're getting more revised. And so we're learning more and more as we advance the field, and our indications are really expanding. So what are the alternatives to shoulder replacement? You know, there are still some out there. I don't think that they're as good in the outcomes, but they provide pain relief if you're stuck. You know, I've been to a couple mission trips, and a lot of times you don't get shoulder replacements. You don't get the components. And so there's still abilities, you know, fusions and those type of things are a reasonable option in a really painful patient. Also, humeral head resections. So still, I would say arthritis is the most common. Osteoarthritis is the most common we see here. What I would highlight here is where the advancements are is that posterior glenoid wear and our understanding of the biomechanics of this are really where right now the current literature is. It's focused on that. So the modern prosthesis, I think we're trying to learn how the differences in sizes are. The difference is in conformity and understanding the variable glenoid structures or designs, and better at our precise instrumentation with imaging advances. We heard yesterday a bunch of imaging talks. And what we know is with imaging advances, we're really improving our ability of understanding what the pathology is, which helps us understand how to recreate the anatomy. And so I have a couple studies that I've published recently looking at 3D CT imaging. So if you do reformats of the CT scans and try to understand where your bone loss is, where your biomechanical eccentric loading is, then maybe perhaps in surgery we might advance our abilities intraoperatively to correct that. So this is what I was talking about, the keel versus the peg. I'm a true believer of the peg glenoid. A keel is like a sail, and you don't get 3 points of fixation. You don't get rotational or stability there. So with the central peg, you can see this is just a bone ingrowth study in dogs. You can see that there's ingrowth around it. So we're minimizing the cement to try to maximize the fixation. So we just kind of reviewed total shoulder arthroplasty. I just wanted to highlight the differences between totals and hemis. So hemiarthroplasty, I think, is for when the glenoid's not arthritic in a younger patient. Sometimes if you have an irreparable rotator cuff, we've learned that if you don't have a rotator cuff that is fixable or that is providing stability to your shoulder, sometimes then what happens is you get a wiggle effect or you get eccentric loading on the glenoid and it fails. So then you shouldn't be putting in a glenoid. You should be doing a hemiarthroplasty. And then I'll tell you the next phase of where we've advanced is now we've talked about reverse shoulder replacement. But really just to understand that there's indications that are different between the two. This is just a simple case. It just kind of shows you how improvement in imaging, and I don't have the CT scan. I tried to put the video in, but it didn't work. But bottom line is you can see here the eccentric loading, right? You can see the loss of balance. It's not centered here. Is this?
You need the second one.
So right here you can see it's loading. The center of this humeral head is flattened. The contour is not the same. So the soft tissue balancing will be different. And the center of the humeral head is really loading through the back here. So what we try to do is we try to center that, improve that. So you recontour it, you place that an anatomic humeral head in that's centered in the glenoid. So that's really what we're trying to do. So just to review, total shoulder is a new, these are the top myths. I think this is sort of kind of a revisiting of 2014. Total shoulder is a new procedure. Range of motion does not improve after shoulder replacements, has a high complication rates. We aren't as good at it as we are compared to hips, and it doesn't last as long. Humeral head is as good or equal in terms of outcomes compared to total, and pain relief is unreliable. These are probably most of the myths that nowadays I could tell you with certainty we've disproven. But these are things that I think that sort of over the last 30 years we've learned and advanced. So just real quickly, I just wanted to talk about the caveat and that probably the newest growth. Sorry about this.
I couldn't find it. So, it's at the side. Okay.
Okay. So the newest improvement that we've done is with shoulder replacements is understanding when you don't have a rotator cuff that's functional. And this is an area, when you look at it, actually, our population, if you look at 80-year-olds and you do MRIs of every 80-year-old, 60% of them will have rotator cuff deficiencies. So it's a huge age in the population. With our aging population, it's a growing industry and it's a growing area of concern. And so we know how to do a shoulder replacement if you have arthritis, but what if your rotator cuff, just because of age-related wear and tear, is deficient? And so that is a special problem that we've tried to understand. In addition, osteoporosis is growing, obviously. Our understanding of it is unbelievable. We are poor at treating it and prevention. And so this is another area of proximal humerus fractures, both in our society and the United States, have just grown exponentially in terms of the type of problems we see around that. So to understand that, you need to understand why this is a problem. When you lack a rotator cuff, what happens is you get a force imbalance, okay? So you get this force, you get a force imbalance that causes the humeral head to migrate up. So it's basically the rotator cuff keeps the shoulder or the humeral head balanced or centered to the glenoid. And you can see without a rotator cuff, you have a force imbalance here. And you get superior migration of the humeral head. You get basically an unstable center of rotation. So you've seen many of a patient that if you ask them, they have a rotator cuff deficiency, you ask them to raise their arm and they do this. They're unable to do it. So it's something that even with a replacement, for a long time, we were not able to treat. So basically, they came up with some things that tried to offset this. This is a fracture stem, so it has less metal to allow for bone healing. And this was sort of a modular first-generation stem that's sort of like a bipolar when you talk about to try to center the forces, right? Forcing it together. So what they did is they tried, and for a while, this is what you'd call a semi-constrained prosthesis. So we lose the muscle balance. You can't have an unconstrained thing because there's no balancing of the components. So then we say, okay, let's just force them together. Forget about the muscles. We're just going to force the two things together, and then maybe we'd get people to be able to work even though they don't have the muscles. The problem with that is they failed horribly. So these were the first semi-constrained or constrained type components. This was their first generation kind of reverses. And you can see here, there's a lever arm here. You're trying to bring it out, and kind of it's like a ball and socket joint, right? This is another one. So it's a fixed fulcrum prosthesis. So this is in the glenoid. This is in the humerus. They just failed horribly because of a couple reasons. There was excessive constraint on the glenoid. The glenoid is a small, tiny little bone. And so it basically failed and pulled out of this glenoid, okay? There's not enough fixation here to be able to hold that in. The forces were too large. So basically you got glenoid loosening, instability, and also the muscle rebalancing here, it wasn't good when you constrained it. So it was very tight. So we're unable to get motion back. So the earlier versions, if you look at all of them, they're horrible, guys. Look at the improvement. None of them seem to improve in motion. Really, I mean, 35 degrees, 55 degrees. So really, they got no functional improvement. Maybe pain, right? But if you look at a rotator cuff deficient patient, usually they don't hurt as bad because the two bones are not even touching each other. One's heading up here, one's down here. So really, the pain is related to more functional disability. And so this was really not a great functional outcome. And then the reoperation rates were up to 30%. So what was the solution? Basically, the Grammont style prosthesis came out of all of our first generation of learning the reverse. And this, instead of having a fixed center of rotation, basically instead of keeping it lateralized, they medialized the center of rotation here. So instead of, you see that, remember you saw that little neck with the little ball out there? They brought that ball back toward the glenoid, so they medialized the center of rotation. And they lengthened the humerus, so they brought it down. They medialized and inferiorized it. And this allowed the lever arm to facilitate the use and the power to be done by the deltoid muscle. That's still sufficient. So it's a semi-constrained joint with medialized, which improved it. You see the difference here, guys? You're bringing it down and you're bringing it over. And so that center of rotation change made it much more advantageous for the deltoid muscle and the remaining rotator cuff. So the results from this improvement have been significant and really changed the way we do shoulder arthroplasty. The reverse shoulder arthroplasty was only USDA approved in 2003 in the United States, and it is crazy. It's probably a 550% growth over the last 5 years. So it's an unbelievable population that we've been able to start to treat. So like I said again, it reduces torque and it changes the center of rotation. So reverse shoulder arthroplasties are for patients that have pain or they have rotator cuff deficiency. It used to be that you had to have rotator cuff arthropathy. That was sort of what we considered arthritis, the superior migration, that irreparable rotator cuff. Nowadays, people are using it for failed shoulder prostheses. People are also using it for irreparable rotator cuff. You just have a big rotator cuff tear. You might not have even any signs of arthritis. People are putting a reverse in. You have a proximal humerus fracture, really bad comminution. Reverse is the highest number one indication now is proximal humerus fractures. So the key, though, is it's not for everybody. It's really important to understand that the reverse shoulder replacement is not something that has been proven over the test of time. We understand initial things, but there's no long-term outcomes, and the survivor rate we still don't understand. So overall, the severity of pain, you need to make sure that it's an older patient because the long 5 to 10-year outcomes are not as good. And then surgical considerations. I think it has to be the right patient. You still have to have the right ability to rehab them and power it with the deltoid. And the complication rates are pretty high with the reverse. So you need to make sure you're keeping diligent to your indications. This is just an example of someone with the preoperative indications for it. And you can see how much that changes, guys, with that center of rotation. Oh, that video is not working. So anyway, so the early experience was good, but the biggest thing is survivorship is really unknown at this time. There are a couple studies out by some of the French that have talked about 5-year, 10-year survival being okay, but there seems to be a fall-off after 10 years for survivorship. And then therapy-wise, just to talk about this, overall the therapy for both of these, we start early with it. We get them moving early. It's kind of like a total hips and knees. You want them to move right away. But you're usually with the total shoulder worrying about your subscapularis repair. With the reverse, it doesn't seem to matter. So with the reverse shoulder replacement, we're getting people moving much quicker without any restrictions. So this just kind of goes through it. And then basically, I think the 3 phases are the keys for it. If you ever see a patient, or for us that we're understanding is 1 is passive motion, 2 is active strengthening, and then 3 is really focusing on whatever the deltoid strengthening. Most of my patients say it feels like a really bad workout. They're sore for a long time because their deltoid's overstretched and overused. And so the one thing I would say with the reverse is there have been 2 studies that have contralateral sided, so one side has a total shoulder, the other side has a reverse. And patients are able, the work to rehab on the left side where the total shoulder would be is much harder than the work on the right, but the total shoulder still feels much more like the original shoulder. And then the reverse shoulder does not feel normal. And they're very limited in external and internal rotation. So you do not get total restoration of normal function there. So that's something that's a caveat for a reverse that's unlike a total. And then you can see here, when I say you don't get restoration, it's still different. So there's still a lot to learn about the reverse. We're still trying to understand why the survivorship doesn't last, who's the right indications for it, and decreasing complication rates. So overall, I think both of them offer pain relief and improved functions. I think the key is really being careful about who we do it in and really being meticulous about the surgeons that are allowing to do it and trying to be better about understanding how we rehab these patients.
Okay, thank you for this very nice overview of the shoulder arthroplasties. I think we have time for some questions from the audience.
Thanks a lot for a very good presentation. I had a couple of questions really.
Mm-hmm.
First one was obviously with shoulder arthroplasty or even with reverse arthroplasty, similar to hips and knees. Once they need revising, you're left with very little bone stock.
Mm-hmm.
So the first question was, if they do reach a stage where they don't need revising, is the next step mainly an excision arthroplasty, or is it more of a larger implant that you use?
Mm-hmm.
Yeah,
so for a total shoulder replacement, the implant, the polyethylene, tends to be able to be removed, and there's some studies out there on 2-stage or single stage. The nice thing about the reverse is really the fixation is much more robust. And so people are putting in bone grafts and then using a reverse just to fix it right away. Back before the reverse was, people would put bone graft with a hemi replacement. And a lot of patients seem to do okay even with that. And some people don't want the revision. And then, however, if your bone stock is really bad and you've lost what I'd call the vault or the cortical walls of the glenoid, in general, people do start to recommend the 2-stage. Otherwise, if it's just central bone loss, people are converting to a reverse right away. I do think that the revision arthroplasty crowd, however, in general, those patients, if you look at the outcomes, they're still nowhere near as good as the primary. So you're still sort of buying them some improvements, but really not normalizing their function.
Okay, and just sort of leading on from that, are there any options, or in your experience, have you come across any areas where you could use localized resurfacing options for shoulders for isolated defects, as opposed to, for example, in knees you have your hemicaps, biopolys and things like that can buy you some time and delay your joint replacement. Is there any sort of long-term studies in shoulders regarding that?
So, Dr. Miniaci came up with an arthro resurfacing thing. So it's a small defect size metal that seems to be that is an option for younger patients for small defects. I think our ability to detect that early and patients wanting those procedures is somewhat of a difficult thing. So I think that the outcomes have not been robust. They've been case series, not comparative. So I think, it's probably going to be something we'll see in expansion in the future, just like uni knees. I mean, I think there is probably a growing area, but I think it has not really sort of come to light as much. And question with the non-weight bearing joint is do they really provide enough improvement?
Thank you.
Other questions?
Valentin from Switzerland. Just a question about the indication for standard prosthesis or a reverse one. If in case of a lesion of the supraspinatus alone, or quite a small lesion of the rotator cuff, what you do? Do you repair the rotator cuff and implant a standard prosthesis, or you go straight for a reverse one?
So Dr. Iannotti has a study that small rotator cuff tears, you can consider repairing them and doing a total shoulder replacement, and they seem to do okay. Definitely you don't want fatty atrophy, or it can't be chronic in nature, but in general those seem to be okay. But you're right, what's interesting is I've seen among my colleagues and people in the field of shoulder replacements are starting to push, or if there is question, people are starting to use the reverse over the total, even in questionable cuff, even if it's intact but it's weak, or patient's 80 years old and you're worried about that. The one thing is out on the market just recently is now we have convertible stems where you can put in the same humeral stem, pop off the head, and convert it to a reverse without taking out the implants. And that's become a much more interesting option for people. But the problem is, again, on the glenoid side. So then, but people are actually just drilling. They'll pop the glenoid off, they'll pop the plastic off and drill through the peg and then just put a reverse in. So I think there's some areas of, this is an area that I don't think it's more experiential than evidence-based. But I definitely think that you're right. I have had numerous patients where I've questioned their cuff integrity, and my mentors and people that advance in the field say just do the reverse.
Any more questions?
I have a question. In the normal arthroplasties these days, what is the survival rate, and what do you recommend for sports or occupational loading and things like that? Can patients do normal activities, or do they have to restrain their...
So I think that the survivorship of a total shoulder is somewhere in the 90% now. So it's almost equivalent to hip and knees.
And how many years?
And that's 10 years. 5 and 10 year survival rates have been shown to be somewhat in that area. So I think we've really advanced in that level. So people say above 95%. It just depends on the patient population and age. And then second of all, interestingly enough, I think the reason why I put in rehab in there is because, interestingly enough, I don't think we focus enough on that. And like you said, I went to a symposium in in an international Congress of Joint Replacement Surgeons, and around the room there was a guy from Mayo, a guy from Harvard, a guy from, and everyone's postoperative restrictions and protocols were different. I do think, however, most people say with an anatomic shoulder that they say that you probably are able to you're able to do almost anything, and they don't have restrictions other than bench pressing more than your body weight. That's something that for some reason people have talked about. Second of all, for a reverse, people do recommend a weight restriction. So they say no greater than 25 pounds or 20 pounds and no repetitive stuff. The highest failure rates have been people going back to labor jobs with a reverse shoulder replacement, which is mostly, I think, why we've directed the focus of keeping a restriction for reverses over 70 years of age, because we think that those people tend to be less weight-bearing and overall repetitive loaders.
Dr. Sajic from Slovenia, from Europe. On the other side, I think that we have now to encourage our patients with any kind of prosthesis, with some sports activities, because you have to know that bigger the forces are, and with the time you will have more wear and osteolysis between prosthesis and bone, or cement and bone, on any kind. So I tell my patients, when you have your own shoulder or knee or hip, you can do what you want if there is not a lot of bone loss or some cyst or something like that to prevent the fracture. So you will have a pain after sports activity. But after joint replacement, I recommend you not be very sports active if you want to have long life prosthesis. This is my recommendation for my patient.
And I think a lot of people would be in your boat as physicians. What I think is the lack of awareness, or sort of the reality of what patients are really doing and who's really following our restrictions. And so it's interesting if you get on the web, and there's there was a paper that was just recently out talking about patients' reported activity levels versus the actuality. And there's actual websites talking about, even with hip and knee replacements, people doing Ironmans. And so I think that I think it's a very reasonable thing to have restrictions. I think an understanding of what happens and the consequences, and a true maybe restrictive thing with outcomes is something that we probably need to focus on in the future, because I think our patients are becoming more and more active, and I think the reality is, whether we believe the restrictions or not, they're still pushing those. And I think for shoulder replacements, I believe there might be a difference compared to hip and knee. So truly understanding what people can and can't do. You know, golfing, for example, is something that sort of the early evidence shows that it's probably not so bad. So we just need to sort of understand that patients push the limits, and then try to maybe study that in a more systematized way.
Yes, but in such cases, for a young arthritic shoulder, in an active guy who like to play tennis or golf, and with a severe arthritis, so you can also propose only to replace the humeral side with maybe a bigger head, and then to tell him that he will maybe suffer a bit, but he can maybe play. No? Isn't not.
Yeah, I think that would probably be the recommendation. I think most people would say, in someone that is going to push still limit, that you don't do the replacements in the same way. You would probably not consider a total or a reverse. So I agree. And I think that the key is, we do want the longevity of our prostheses to last. And so I think you tell them, and all we can do is educate them. I think that it's interesting, though, is just we don't have enough evidence-based medicine, and I think the shoulder, the newer component, modern prostheses for the shoulder. And I think we're learning more. A perfect example to me is the hip metal on metal, and understanding that, and we're doing things and advancing things, thinking that we're doing better for younger patients, and look where we are. So, I think there's a lot to be said about that, and understanding those before we sort of start changing our practices.